All right, I'm recording. Share my screen. For the point. All right, so this is video number 5 and the final video of this assignment, Obstructive Shock by Kyle Ortega. All right, so what is obstructive shock? It's a blockage or obstruction that impedes blood flow, leads to inadequate tissue perfusion. Common causes include pulmonary embolism, cardiac tamponade, and pneumothoraxes. Physical exam findings include hypotension, respiratory distress, tachycardia, tachypnea, air hungry, dilated, engorged neck vein, and chest pain. Signs and symptoms, signs of decreased cardiac output, shortness of breath, altered mental state, chest pain, swelling in the legs, which is a DVT that leads to pulmonary embolism, dilated, engorged neck vein, which could signal pneumo or cardiac tamponade, because basically that the engorged neck vein makes the inability of the blood to return to the heart. And then hyperresonant percussion, distended veins, absent breath sounds, all the telltale signs of a pneumothorax. All right, so the imaging studies used to diagnose the shock, CT pulmonary angiogram for pulmonary embolism, visualize the blood clots or other obstructions, echocardiography for cardiac tamponade, identify presence of pericardial effusion, chest X-ray for pneumothoraxes, PE, or cardiac tamponade, and then EKG, which reveals specific abnormalities in PE and cardiac tamponade. So like for PE, it's going to be right heart strain, and then cardiac tamponade, you're going to see low voltage electrical alternans on the EKG. Hemodynamic monitoring. So just like everything else, we're going to use a pulmonary artery catheter, a central venous catheter to monitor the blood pressure, cardiac output, pulmonary capillary wedge pressure, and we're going to monitor the central venous pressure as well. So in obstructive shock, you're going to get an increased heart rate, increased pulmonary vascular resistance, increased central venous pressure, and as well as increased pulmonary artery pressure. We're going to get a decreased blood pressure, decreased systemic vascular resistance, and cardiac output. And these hemodynamic changes lead to systemic hypotension, which impairs oxygen delivery to tissues and organ dysfunction, aka life-threatening. Pharmacology and treatment. IV crystalloid fluids such as saline, anticoagulants, thrombolytics for that pulmonary embolism, vasopressors, inotropics. But my research did say you want to caution in cardiac tamponade because it may worsen the condition by increasing that systemic vascular resistance. Also, surgical interventions may be needed, to either take that, get that blood for the blood clots, and then a pericardiocentesis to relieve that fluid around the heart may be needed as well. Arterial blood gas abnormalities and mechanical ventilation. So we'll start with mechanical ventilation. This one is really tough to find. Researching, it was really tough to find a lot of information on mechanical ventilation, but I did finally get some info. So the research I found said low tidal volumes and low PEEP pretty much following that ARDS recommendation because of that high right ventricular afterload. And then since hypercapnia can further increase pulmonary resistance, it should be avoided as well. And then just regular reassessment. ABG wise, hypoxemia, metabolic acidosis, um, respiratory alkalosis or acidosis, which means, so like for a pulmonary embolism, it'll initially be alkalosis, but as the condition progresses, it turns to acidosis and retains that CO2, where at beginning it's blowing, that CO2 is low, and then it turns to acidosis, which is hypercapnic and retaining the carbon dioxide. So some positive pressure volume, excuse me, positive pressure ventilation concerns. I did find a lot of these. This wasn't hard to find in the research. So it can impede that venous return to the heart in cardiac tamponade, further decreasing cardiac output, impacting perfusion. It can exacerbate hypotension and compromise blood flow in a pulmonary embolism. And then and it could contribute to barotrauma. This could be a tension pneumo. So those are some pretty grave concerns. I guess that's why I did find a lot of research, because all the treatments and everything, it doesn't exactly scream put them on the vent, but you know, we have to. They can't keep their airways open. All right. So to kind of summarize obstructive shock, it's pretty much anatomical obstruction of the great vessels of the heart. Um, it's a life-threatening condition that decreases cardiac output due to obstruction, leading to inadequate tissue perfusion, uh, shortness of breath, swelling in the legs, chest pain, overdistended jugular vein, hyperresonant percussion. Could all be signs. Hemodynamic wise, increased heart rate, increased central venous pressure, increased pulmonary vascular resistance, increased pulmonary artery pressure, then decreased cardiac output, decreased blood pressure, and decreased systemic vascular uh, resistance. And then treatments include anticoagulants, vasopressors, inotropics. And then, like I said before, some surgical interventions may be needed, whether it's getting fluid around the heart or removing the blood clots that can be life-threatening. But mechanical ventilation wise, low tidal volumes and low PEEP settings. Um, that pretty much wraps up hemodynamics and circulatory shock. My next few slides, like I've been alluding in the earlier videos about my sources, I have 3 slides of sources. I'm not sure if we were supposed to send these so you could click on them, but just let me know if I have to. But here's the first slide. It's a lot of research. And it took a long while. I had to read all kinds of stuff. But that pretty much wraps up my presentation and my series of videos for this assignment. Thank you for listening, and I will stop sharing and pause the video. Thank you.